Blood pH regulation is one of the most tightly controlled variables in human physiology because even small deviations can significantly alter protein structure, enzyme kinetics, membrane excitability, and oxygen delivery. So we have to remember that normal arterial pH is maintained around 7.4, reflecting a delicate balance between acid production and buffering, ventilation, and renal excretion. Throughout this lecture, we're going to focus on how the body maintains this balance in the face of constant metabolic acid generation and how failures in these systems present clinically as acid base disorders. This feels like a shift from where we have been discussing thus far, but it's important to understand this tie back before we get too far into our respiratory mechanisms and forget that one of the major purposes of respiration is to drive in oxygen, exhale carbon dioxide, and then perfuse our tissues. So, the concept of homeostasis, as we remember, refers to the body's ability to maintain a relative stable internal environment despite external and internal changes. For pH, this stability is achieved through layered defense mechanisms, such as immediate buffering systems can act within seconds, while the lungs and kidneys will provide a slower but a much more powerful regulation of acid-based mechanics. Buffers do not eliminate acids or bases. Rather, they are minimizing a rapid change in hydrogen ion concentration until definitive removal can occur via respiration or kidney function. This tiered approach is essential for our survival. Acid-base buffering systems prevent a dramatic shift in pH when acids or bases are introduced into the body. The most important buffer in the body, specifically in the extracellular fluid, is the carbon dioxide bicarbonate system. While hemoglobin plays a critical buffering role within a red blood cell, intracellularly, phosphate buffers and protein side chains, particularly histidine residues, accept or donate hydrogen ions. So together, all three of these systems are going to ensure that both blood and intracellular pH remain compatible with normal cellular function. But the one we really got to know the best is this carbon dioxide bicarb buffering system. So, as a reminder of this system, carbon dioxide is continuously produced as a byproduct of aerobic metabolism, of aerobic respiration, of glycolysis, the Krebs cycle, oxidative phosphorylation, etc. In an aqueous or liquid environment, carbon dioxide combines with water to form carbonic acid, seen here. Carbonic acid, once formed, rapidly dissociates into hydrogen ions and bicarbonate, HCO3. This reaction, though, is reversible and it's catalyzed by carbonic anhydrase. This is the enzyme required to form for formation of carbon dioxide or for formation of carbonic acid. So carbonic anhydrase is governing this kind of equation right here. Okay, this will rapidly dissociate and can rapidly move back and forth between carbonic acid and bicarb. So this can move on its own depending on the system. This, though, requires this enzyme. I think that's a key component to remember. Um, Carbonic anhydrase is particularly working hard and working more inside red blood cells as well as inside renal tubular cells, the cells that line the tubes in our kidneys. Clinically, the system will link ventilation directly to pH regulation, making respiratory function a key determinant of acid base balance. The Henderson-Hasselbalch equation, I know, not thinking we're going to have to pull that through from biochemistry, but this provides a quantitative framework for understanding blood pH. At physiologic pH of 7.4, the ratio of bicarb to dissolved CO2 is approximately 20 to 1. So that means there's more bicarbonate than CO2 on average. This is bicarbonate, importantly to note, is regulated by the kidneys primarily, while CO2 is primarily regulated by the lungs. Now, there's some differentiation between those, but for the most part, bicarb concentration is governed by kidneys, carbon dioxide concentration is governed by the lungs. So the separation allows independent control of the numerator, bicarb, and denominator, carbon dioxide, which allows us to kind of explain why acid-base disturbances can be classified as metabolic, really focusing on bicarb dysfunction or kidney dysfunction, or respiratory, focusing on carbon dioxide or lung dysfunction in origin. Okay. So then going to our buffering system, in clinical practice, carbon dioxide is measured as partial pressures rather than as a total concentration. Arterial partial pressure of carbon dioxide normally sits around 40 millimeters of mercury. To use this value in acid-base equations, though, it has to be converted into an effective concentration of dissolved PCO or of dissolved carbon dioxide. This distinction is clinically important, especially when interpreting an arterial blood gas and then assessing ventilatory adequacy in someone who's critically ill. So remember, you're seeing this as a partial pressure, but to really understand it in the basis of Henderson-Hasselbalch, you have to convert it into a concentration. Disruptions then in acid-base balance occur when buffering, ventilation, or renal handling of acids and bases becomes impaired. These imbalances can be life-threatening because the pH affects cardiac contractility, vascular tone, neural excitability, and even oxygen hemoglobin affinity or binding strength. Recognizing whether the disturbance is primary or compensatory is central to clinical interpretation. So we have metabolic versus respiratory, and we have primary versus compensatory. Here's some definitions for us. Acidosis. When a pH disturbance originates from altered CO2 levels, it's classified as respiratory in origin. Conversely, disturbances caused by changes in bicarbonate concentration are metabolic. This distinction reflects the organ system primarily responsible for the abnormality. Understanding this framework allows us to rapidly identify the source of the disorder and anticipate appropriate compensatory responses. Acidosis is any state in which the pH drops below 7.4, the typical normal range. Alkalosis is any state where the pH raises above 7.4 or becomes more basic. So let's practice. This table is showing a simple disturbance of an acid-based balance. Right? Increase or decrease to indicate the change from normal parameter values. So we have our normal pH of 7.4, we have our bicarb concentration of 24, and we have our partial pressure of carbon dioxide in blood at 40. So again, rather than memorizing these values, the goal is to understand directional changes. So when filling out a table like this, ask first, is the pH acidic or alkalotic? So in acidosis, the pH is always going to be acidic, so that means pH in these instances is going to go down. Versus in alkalosis, the pH is going to raise. So we already can fill out this first part of the table by just looking at acidosis versus alkalosis, and then we can figure out the pH. So pH is done. This then is going to determine, then after you've determined that, determine whether the primary disturbance lies in CO2 or bicarbonate. This logical sequence will mirror real-world clinical reasoning, and it's foundational for interpreting arterial blood gases. When we look at metabolic acidosis, the problem is initially going to be with bicarb. So this is going to be the primary problem with metabolic stuff. It's going to be bicarb. Versus respiratory is going to be, the primary problem is going to be with carbon dioxide. So in a metabolic acidosis, if we have an acidic pH, what's happening to our bicarb? Well, our bicarb is going to have to go down in concentration because that's the basic buffer. So when it goes down, then we are pushing ourselves into more of an acidic state. We'll also see then that we'll have our PCO2 go down as a compensatory mechanism. Metabolic alkalosis is going to show an increase in bicarbonate to get us to that alkaline state. And then we'll see a compensatory rise in our CO2, an increase in our CO2 value. So this would be our metabolic acidosis and our metabolic alkalosis. In respiratory acidosis, we're working first with PCO2, or our CO2 concentration. So carbon dioxide is the acid in this world. It's not bicarb. So in respiratory acidosis, we're going to see carbon dioxide increase, and then we'll have a compensatory increase in bicarb. In respiratory alkalosis, we'll see a decrease in our acid, a decrease in carbon dioxide, and therefore compensatory decrease in bicarb. So now we've filled out our chart and we can see this here. So here you can see how pH, bicarb, and PCO2 shift in predictable directions depending on the primary disorder. Note that compensatory responses often move in the same direction as the primary change, but do not fully normalize pH. So this concept explains why a normal pH does not always mean normal physiology and why compensation should never overshoot. So, what are some causes of respiratory acidosis and alkalosis then? Respiratory acidosis commonly results from hypoventilation. So, we are keeping too much CO2 in the body. This can be seen in chronic lung disease, neuromuscular disorders, or central respiratory depression. Over time, the kidneys will compensate by increasing bicarbonate reabsorption. In contrast, respiratory alkalosis results from hyperventilation, often due to anxiety, head injury, drug toxicity, etc. Renal compensation occurs via increasing bicarbonate excretion. Versus a metabolic acidosis and alkalosis, metabolic acidosis arises from either excess acid production, impaired renal acid excretion, or loss of bicarbonate. The lungs will compensate rapidly by increasing ventilation to lower carbon dioxide concentrations. So they try to get rid of more CO2. Metabolic alkalosis is often caused by vomiting or excessive bicarbonate intake. This could lead to hypoventilation as a compensation. However, respiratory compensation is limited by the need to maintain adequate oxygenation. So, where are these acids, these hydrogen ions coming from? Well, a critical concept is that acid base balance is not just about disease states, but it reflects everyday metabolism. The oxidation of dietary proteins is a major source of non volatile acids, meaning acids that cannot be excreted via the lungs. This places a continuous burden on our renal acid excretion mechanisms, our kidneys. Protein and amino acid metabolism generates strong acids such as sulfuric and hydrochloric acid, while nucleic acid metabolism produces phosphoric acid. Mixed diets typically generate a net acid load, whereas diets rich in fruits and veggies generate bicarbonate precursors. Clinically, this helps explain differences in urine pH and has implications for bone health, kidney stone formation, and chronic kidney disease progression. It's not saying one diet is right, wrong, or otherwise. It's just saying that a diet that's heavier in animal proteins and it's going to be harder on the kidneys and harder on that acid overload than a diet that's more rich in fruits and veggies. The anion gap reflects the presence of unmeasured anions in plasma and is a powerful diagnostic tool in metabolic acidosis. Sodium is the dominant measured cation, while chloride and bicarbonate are primary measured anions. An elevated anion gap suggests accumulation of acids such as lactate or ketones, while a normal anion gap acidosis often reflects bicarbonate loss with chloride retention. At this point, I encourage you to integrate mechanisms and clinical scenarios. Prompt questions around arterial blood gas interpretation, compensation limits, real world cases such as diabetic ketoacidosis or COPD exacerbations. That will help solidify these concepts and help you be able to clinically apply this material.